Yeah, I think few are joining.
ಒಂದರಿ ಆಪ್ಷನ್
Yeah, fine. We'll start. I'm again checking the audio. Am I audible? I hope the video audio is fine and the slides are visible. Is it okay? Okay, fine, fine. So we'll start off with today's session. What is the topical fluorides? So topical fluorides, or the term topical fluorides, are used to describe those delivery systems which provide fluoride for a local chemical reaction to exposed surface of the erupted dentation, which means that these are the modes of application of those agents or those systems on the topical surface, that is the superficial surfaces of the teeth. This is usually done soon after the eruption of, as a teeth erupt into the oral cavity, it has been done soon after it has been erupted. Hello, I'm sorry for the inconvenience. I just lost the connection. Yeah, so we can classify the topical fluorides into two. One is your professional applied and self applied. As the word says, it is self explanatory. Professional are those fluorides or the topical modes of fluorides which are applied by a dentist or any professional or dental hygienist or dental therapist, etc. All any auxiliaries, when they apply, they are called as professionally applied. And the examples of professionally are neutral sodium fluoride, stannous fluoride, APF, varnish, fluoride varnish, fluoride containing restorative materials, and fluoride releasing devices. So these are some devices which are impregnated into the tooth surfaces which release fluoride. So here the most important part is the topical fluorides have been delivered at a very higher concentration, around 5,000 to 19,000 ppm. So that is one major difference between professional applied and self-applied. When you apply, when a dentist or a professional can apply, they can apply it to a very large concentration up to 5,000 to 19,000 because it is under their control. They can supervise it. But when you are doing an unsupervised administration of fluoride, like your self-applied, you just give, or those modes will have a less concentration, that is 200 to 1,000. So you can find the best example is all your toothpastes. Toothpaste have maximum the fluoride content will be till your 1,000 ppm. Toothpaste, so these have a ppm till 1,000 ppm. Most of the toothpaste, if you look back, they'll be labeling, they'll make a mention, a note of what is the fluoride content in the toothpaste. So dentifrices, mouth rinse, gel, fluoride chewing gums, and fluoridated toothpicks and dental floss are examples of self-applied. So these are applied by the patient, where you prescribe to the patient, they can do by themselves. They don't need much supervision because the fluoride content is less. The whole purpose of mentioning, or whole purpose of regulating the amount of fluoride is to prevent toxicity. Right? So today we'll be discussing about the most important type of professional applied fluoride, which are sodium fluoride, stannous fluoride, and APF. Yeah, we won't be discussing everything because it's a huge section. So we'll just discuss the most important three fluoride delivery three important types of fluorides. And let's see what are the indications. So the most common indication, as we all are aware, it is the caries activity. The caries activity determines whether a topical fluoride or any preventive modality or preventive techniques has to be applied to a patient. So how do you identify whether an individual is caries active or not? The most simple chairside technique is recording an index. Your DMFT index is a very conclusive index of giving your caries activity. Or you can go for a karyogram, or you can even do a caries activity test to identify whether whether the child or whether the patient or adult is a caries active. So most common is your DMFT scores. If you have a higher DMFT scores, so this is called as a cumulative aspect, cumulative index, which represents both your past and present experiences. So you know what is the past of the patient in terms of caries. So based on that, you can say or call a patient to be caries active. And then soon after tooth is erupted, it has been said that the best time to apply any topical fluoride is as soon as the tooth erupts. Clear? So for example, if your molars erupt by an average of age of 6, within the first 2 to 4 years is a very critical period where the tooth undergoes something called as post-eruptive maturation, where the minerals get calcified and mature enough. That is the best time where the maximum absorption of fluoride happens. And it has been also quoted in the literature that when the primary when the teeth erupts, and during the primary period when it is getting matured, it is those period where the enamel is more porous and the fluoride entrapment and fluoride capture will be more fast and rapid. And obviously those who take medications, and there is always there is a direct relationship between salivary flow, salivary rate, the constants of saliva, and the caries. So where the salivary flow and rate is compromised, those are prone for developing caries. And after periodontal surgery, when the tooth are exposed, we know that we have studied that there are a lot of literature quoting that when the tooth is exposed, the cementum is exposed, root are exposed, the chances of getting caries are higher. So in those patients, you do caries. So caries active individuals, soon after eruptions, people who are doing periodontal surgeries, and those who are doing taking medications which decrease or compromise the salivary flow. Then patients with fixed and removable processes. This is again in terms of the oral hygienes. Patient with eating disorders. It has been said that people who are having eating disorders like bulimia, anorexia nervosa, the oral hygiene or oral health is always complex and it is complicated. So that is the reason why there would be more chances of lesions. So to prevent it, it is advisable. And mentally and physically challenged individuals where physical and manual dexterity is always compromised. So best choices when you get an option, like what are the conditions which decides whether a patient need a fluoride or not. It is definitely based on the age is a very important criteria. That is why it stands first. And out of the age, it is always the younger children where the teeth is being erupted, or during the period of eruption, or it is undergoing a maturation. That is the best period to deliver fluoride. Education in terms of, I want to say that education is overall the socioeconomic status, and it is related to the caries. Oral health habits, people who are having a poorer habit need or they'll have a higher status of caries, so they need application of topical fluorides. And physical dexterity. Now let's see what are the first type of sodium fluoride. The first type of fluoride is your sodium fluoride. This is the first developed. It was developed in the year of 1941, and it was first suggested and recommended by a person called as BB. So the studies are usually said as BB et al. So this is a person who first did a studies on sodium fluoride, where he found that when sodium fluoride combination is given onto the tooth, so topically it has been applied, there is a suggestive reduction of caries. Later, the major name which we always come across with respect to sodium fluoride is your Knudsen. That is 1942. Knudsen suggested the techniques which required 4 visits. Very important. Please remember the numbers. 4 visits. 1942 it was Knudsen. And the concentration of sodium fluoride what we administer is 2% with a pH of 7. So that is the reason why sodium fluoride is time called as neutral sodium fluoride. Neutral sodium fluoride because it has a pH of 7 and carries reduction of 30 to 40 percentage. So the some standard textbooks follow 30 percentage, and I have given the range of 30 to 40 because some MCQ books have answers up to 35 to 40. So it's better to remember it as in the range of 30 to 40. So if you get any options between this, that will be considerable. You can consider it as an answer. So you have 4 applications, and it is done in uh, 4 different ages. You're supposed to do a sodium fluoride application in 4 different ages. We'll see what are the ages. And 2% sodium fluoride is prepared by 20 grams of powder in 1 liter of distilled water in a plastic bottle. So here something is very interesting about sodium fluoride. It does not have any reaction with the glass. Unlike your other fluorides which corrode and react with the glass, you're safe enough to store sodium fluoride in a plastic bottle. So you prepare it by 20 gram in 1 liter, that is 1000 ml of water. The concentration is 2%. The technique of application of sodium fluoride is known as Knudsen technique. That is why it is always, when you take the name of sodium fluoride, the name Knudsen's come into picture, because he was the person who first developed the technique of application of sodium fluoride, which is Knudsen. 4 appointments, a gap of 1 week, at the age of 3, 7, 11, and 13. Very important ages, very important age groups, 3, 7, 11, 13. So you give this particular application of topical fluoride in all these age groups, when the child is 3, when the child is 7, when the child is 11, and when the child is 13. And at each age you recall the patients 4 times. So the only criteria when you're recalling the patient is it should have at least a gap of 1 week. If you're calling it today, after 1 week, you call them again after consecutive 1 days, you call them 4 times at 3, 7, 11, and 13. And the reason why this is being done to coincide with the eruption of primary and permanent teeth. So these are the key ages where you expect at least the most important or keystone teeth to be erupted into the oral cavity. So what are the steps? So the first step for overall all the topical fluoride, the first steps remains the same, that is a cleaning. You can clean the tooth by either hand scaling or ultrasonic. You clean, you make sure the teeth is clean or hygiene is better. And even it has been suggested of cleaning and polishing the tooth with even slurry of pumice. The first step is cleaning the tooth surfaces or oral prophylaxis or cleaning. Then you isolate thoroughly. The thorough isolation is very critical in terms of topical fluoride application, irrespective of what is the type. So it is here they have recommended the application of cotton rolls. Once you make sure the tooth is isolated and dry, very important, it should be dry. The teeth has to be dry. Can dry using your 3-way syringe. You make sure this is dry, the tooth surface is dry. You can do in a quadrant wise topical fluoride application or arch wise. So the application is done by a technique called as paint on technique. So this is paint on technique. You have a small brush, even if not for brush, you apply topical fluoride and you paint onto the, or you just dab onto the tooth surface. Very simple. So that is your application process. Now important is what is the mechanism or how this sodium fluoride act onto the tooth surface. So primarily when sodium fluoride is reacts with hydroxyapatite crystals, the first compound formed is calcium fluoride. Always keep this in mind. Sodium fluoride, this fluoride splits from here, and we know that the hydroxyapatite or the enamel has lot of minerals like your calcium, phosphorus, magnesium, etc. So the most attractive of this is your calcium and fluoride get attracted to each other. They form calcium fluoride. So this calcium fluoride is the first form, and it is we can say it is a must to be formed. It will be formed irrespective of whatever solution you apply, whether it is sodium fluoride, whether it's APF, whether it is stannous. So once calcium fluoride forms, it forms a very thick layer onto the tooth surface of this particular tooth, and it forms, the thickness increases in such a way that it interferes with the further infusion of fluoride into the onto the tooth surface. So this particular inhibition of the calcium fluoride for further entry of this fluoride into the tooth surface is known as chalking effect. Very important question, chalking effect. So chalking effect is related to sodium fluoride, and it is not caused by sodium fluoride. It is in terms, it is caused by calcium fluoride. This calcium fluoride is responsible for causing shocking effect, and it is seen in sodium fluoride. So it is the layer of calcium fluoride which prevents the further entry of fluoride. So this, again, this calcium fluoride, the whole purpose of calcium fluoride formation is you need a reservoir of fluoride. The whatever layer it is been formed, after a few period, this calcium fluoride which has formed a layer, it started leaching out. The fluoride started releasing, and within the oral cavities salivary environment, it mixes with the saliva and it forms a reservoir, which is called as a residual fluoride. So that residual fluoride is very important, because once you finish application, that presence of this residual fluoride enhances or it improves the quality of fluoride which has been uh, formed onto the tooth surfaces. And this final formed product is called as your fluoridated hydroxyapatite. This calcium fluoride reacts with again hydroxyapatite to form fluoridated hydroxyapatite. So this is the most desired product what we want on the tooth surface. Resistance to decay. It is resistant to dissolution. So that is the most desired product. So this is all about a sodium fluoride. Points to be remembered is Knudsen, calcium fluoride, shocking effect. Next, advantages of sodium fluoride. It is a very stable product. It can be kept in plastic, even kept in plastic. Its taste is well accepted. It does not irritate the gingiva, does not cause the discoloration. So these are when compared to other solutions. The only disadvantage of sodium fluoride is number of visits, number of application. 3, 3, 7, 11, 13 application. This age groups you need to do make 4 visits becomes little difficult. Now next is your stannous fluoride. So we saw that there are some limitations of sodium fluoride. All the generation of these topical fluorides are as a result of some of the limitations which was encountered during the previous generation. So to encounter the previous limitations what sodium fluoride has, they develop something called a stannous fluoride. The stannous fluoride comes under two concentrations. So sodium fluoride was your 2%, sodium fluoride was 2%, whereas stannous is 10% and 8%. Clear? It is believed that 8 is for children, 8 is for children, and 10 is for adults. Children and 10 is for adults. But there is no as such evidence saying that there is in fact a difference in the caries reduction. Now the method of preparation of stannous fluoride, it is freshly prepared. So that is the difference what we were comparing with sodium fluoride. Sodium fluoride could be kept as in a plastic bottle, but this has to be kept in a freshly prepared glass bottle. So here, this particular stannous fluoride turns cloudy when it is being stored for a period of time. That is because of the formation of tin hydroxide. This tin hydroxide this tin hydroxide results in the formation of cloudy appearance. That is why it is always freshly prepared. It is prepared by dissolving 8 grams, 0.8 grams in 10 ml of distilled water, where sodium fluoride was 20 in 1000 ml. 1000 ml. Here it is point, it comes in decimals, 0.8 in 10 ml. Here just 10 ml, here 1000 ml. So always try to compare and learn the topical fluoride. It gives more helpful. Here the technique is called as Muller's technique. Previous it was Knudsen technique, here it is Muller's technique. It is simple, the technique of application of stannous fluoride is called as Muller's technique. So let's see how it has been. It is almost entirely same. The only one difference what it has been quoted in the textbook is application of floss. Okay, how much it actually helps, it is a question mark, but that is the only difference what is there in the textbook of application of floss. And whenever you get a question from topical fluorides, you always use unwaxed floss, because waxed floss interfere with the absorption of fluoride. So you have waxed and unwaxed floors. So use unwaxed floors in terms of topical fluoride application. And the technique remains same. You clean that or do oral prophylaxis. So you clean the tooth surfaces. You do flossing in interdental areas. Make sure no debris is present. Then you isolate the tooth surfaces by cotton rolls and suction. Then you again apply the same technique what we done on your sodium fluoride. Same technique, that is your paint on technique you do for stannous fluoride too. Some of the important compounds, or very important compounds which is formed in stannous fluoride, you have two concentration. We know that there is 8% and 10%. So that is what it denotes here: low concentration and high concentration. In a low concentration, you have only tin hydroxyphosphate. You have tin hydroxyphosphate and calcium fluoride. So there are only two compounds formed. So this tin hydroxyphosphate is very important because this is the compound which is responsible for a taste, which imparts a, you call it as a metallic taste or an astringent taste for stannous fluoride. One of the major limitation of stannous fluoride is this taste. It is not at all palatable, and many times patients complains of this astringent or metallic taste in tin hydroxyphosphate. So remember THP, you can remember it as THP, tin hydroxyphosphate, THP, the first compound responsible for the taste. Then again, as I told you in the previous section, calcium fluoride is always formed. When it is high concentration, along with this same calcium fluoride, you have calcium trifluorostannate, and tin trifluorophosphate. So this you can remember at CTF. CTF is calcium trifluorostannate, and TTF, tin trifluorophosphate.
Hello, everyone. Hello. Yeah, as of now, we are receiving a technical issue with Dr. Arun Paul's account. So, how about we wind up today's session and move on to the next session that is on upcoming 31st, right? We are really sorry that Dr. Arun Paul is not able to join back to the same meeting. So we'll find what is the issue, and by the next session we'll be fine. All right. So I'm not receiving any response from your side. We'll inform about the remaining session. All right. We'll arrange another meeting and we'll inform again. Is that fine? All right. All right. So we'll get back to you with another session. This session will be definitely on YouTube and we'll be sharing the link also. All right. Okay then. Okay. So good night. Good night, everyone. Thank you.